But you can't turn your video on first, I assume.
I'll be moving.
Well, hi everyone. I'm just streaming to Facebook. Give me just 1 second. Okay. Okay, hi. Welcome to our first brown bag webinar. Wait, can you see my screen right now?
Yes.
Yes.
You can see Medicare is changing access to diabetes tech, right? Okay. Welcome to our first brown bag webinar under our newly launched program, DPAC Dialogues. You may have seen some of our other dialogues on social media. We have released videos with our board members from conferences such as the American Diabetes Association Scientific Sessions. And we are part of that umbrella. We're also continuing to do our live webinar series, Brown Bags. You also may have seen John Anderson actually on a previous DPAC Dialogues that we released 1 week ago. So today we're talking about Medicare changing access to diabetes technology. You may have seen that on our campaigns, on our social media, on our email blasts in the past couple of weeks. I'm just going to go around and have everyone give a 1-minute introduction, including a brief overview of any experience you have in diabetes and / diabetes policy. We can start with April because she's from the DPAC staff.
Hi, everybody. My name is April Gutman. I'm the Senior Manager of Policy and Government Relations at both Diabetes Patient Advocacy Coalition, DPAC, and DLC, Diabetes Leadership Council. I focus mostly on federal policy efforts, so what's going on in DC, both in Congress and with the administration and agencies like the Department of Health and Human Services, HHS, and the Centers for Medicare and Medicaid Services, CMS, which we will be talking about a lot today. Thank you.
Bruce, you want to go next?
Yes, my name is Bruce Taylor. I've been working with DPAC since its inception. I was their board chair for 7 years. I've worked with diabetes advocacy for the past 35 years. And unfortunately, I've been intimately involved in understanding the Medicare proposed rule and hopefully be able to enlighten you today.
Last but not least, Mr. John Anderson.
Thanks, Amanda. I'm Dr. John Anderson. I practice internal medicine and diabetes at a large clinic in Nashville, Tennessee called the Frist Clinic. I'm a board member and medical advisor for the Diabetes Leadership Council, and I have been a longtime volunteer with the American Diabetes Association, previously serving as president of medicine and science, but I also was chair of national advocacy while I was with the organization. So we've been doing a lot of diabetes advocacy work for a long time.
Thank you. We're really excited to have these 3 esteemed guests today. I'm going to stop sharing so that we can see everyone. Okay, and so we're going to start with Bruce. So what is a competitive bidding program and why does CMS implement such a program? What is their main goal?
Just historically, in 2003, Congress passed legislation. It was during the time when the Part D, or the drug benefit, was being passed for Medicare beneficiaries to have a drug benefit. Part of that legislation was with the DME, or the device side of the world. They wanted to do competitive bidding as a way of lowering costs to pay for the drug benefit. CMS selects categories that are expensive, used by a lot of people, usually in a very competitive category. They submit those to an arduous task of competitive bidding. It's with the suppliers providing bids that ultimately bill Medicare on the patient's behalf for their devices.
And can you talk about past rounds of competitive bidding and how DPAC has been involved in the past?
DPAC has been intimately involved when the first round of competitive bidding was with diabetes test strips and meters. The challenge there is that when the program went in, there were really no safeguards for patients. There were a lot of products coming in offshore into the United States that did not meet the regulatory quality guidelines post their FDA clearance, and patients were disrupted. There's significant disruption. We published a paper in 2017 that looked at the impact. They did save costs on diabetes test strips. However, the increased rate of hospitalization, emergency department uses, and mortality all increased due to the disruption of people being able to monitor and self-manage their diabetes.
Thank you for that insight. Yeah, I know that DPAC was founded due to that initial issue of competitive bidding on glucose meters. April, what does this new competitive bidding proposal look like, and how is it different from previous competitive bidding programs, like the ones that we just mentioned?
Yeah, so the new competitive bidding proposal really contains two pieces. The first is something that CMS hasn't really done before in connection with a competitive bidding proposal, and that is a proposal to reclassify CGMs and insulin pumps as items requiring frequent and substantial servicing. So let me explain what that means and what that change would look like. Currently in Medicare for insulin pumps, it's a rent to own model. So Medicare spreads the cost of the insulin pump over 13 months. And then once you finish those payments, you own your pump, but continue to get supplies from your Medicare DME supplier. Currently for CGMs, you purchase your receiver outright and then continue to get those supplies as well. Under the new model, you would never own your devices. So instead, you would rent the equipment monthly, but never own it. And your DME supplier would be responsible for updating and managing and servicing that device. So we can talk more later about the problems that presents for patients. The second part of the proposal would include the CGMs and insulin pumps in a competitive bidding program. So somewhat similar to what they did for test strips, as Bruce described earlier, where DME suppliers in Medicare would bid for Medicare business. What that would do effectively is reduce the number of suppliers in Medicare from hundreds to thousands, depending on whether you're talking about suppliers of CGMs or pumps, to anywhere from 2 to 10 suppliers. And the thing that is a bit unusual that they're doing this for CGM and insulin pumps is that typically competitive bidding is used for products that are easily interchangeable. And as we know as patients, these technologies are extremely individualized and specialized. Additionally, while CGMs and insulin pumps under Medicare Part B would be included in the program, others would not based on technicalities in the law, which would cause additional barriers. So we can talk more about some of the specifics and barriers that presents.
Thank you for translating that a bit into everyday language. John, from your perspective as a provider, what are the main risks this proposal poses for patients' timely access to pumps and CGMs, especially for people in rural or underserved communities?
Yeah, thanks, Amanda. I'm concerned about the whole process. The fact that we're going to go from many suppliers down to competitive bids of anywhere from 2 to 10. They're asking for an expertise these durable medical equipment companies do not have. I had a lady who was in representing a DME shortly after we had our board meeting, and I brought it up and I asked her, frankly, I said, "You're aware of the competitive bidding process. What are you prepared to do?" She goes, "We are scrambling," because they don't have an expertise in pumps and CGMs. They've never owned the equipment and rented it out. They don't know how to troubleshoot. They're going to have to hire that expertise. If they have to hire that expertise and it doesn't work out, and we've gotten very few durable medical equipment companies, what's going to happen to my patients and access? And remember that this is, again, about disparity, right? I've got patients who could just go this afternoon and buy the pump. They don't care. But then I've got other people who depend on that pump who don't have the ability to go and purchase a pump. And now they're going to be renting these pumps. And if something goes wrong, they're going to require on that DME expertise. Out in rural areas and underserved areas, we a lot of times will get on a telehealth phone call and be able to look in real time at a continuous glucose monitoring tracing so we can troubleshoot, highs and lows and hypoglycemia and where do we need to fix things. So I'm concerned about the rush of this process for companies who don't have this expertise yet. And of course, the business part of this is how are you going to know how to do competitive bidding if you really don't know what you're going to be required to do in the first place?
Yeah, that's definitely, we're all really concerned about this process. We got one question in the Q&A asking at the end of the rental period, will we own the devices or have to return them?
So
Um,
yeah,
okay.
I can address that quickly. So the Medicare beneficiary would never own their device under this proposed model. So this presents problems, like if you're switching suppliers, you may have to give your pump back to your current supplier before going to a new supplier. And that presents a huge, interruption in that patient's care.
Yeah. Um, Going on to our next question, this is now opening it up to the whole panel. I would like to hear from everyone. What do we know about how consistent device use impacts A1C, time and range, and complication rates, and how might disruptions undermine these outcomes?
I guess I can start that. There have been multiple studies that show if you give somebody, particularly type 2 diabetes and type 1 as well, you give somebody a continuous glucose monitor. You don't change their medical therapy, you just hand it to them. What you get is a lowering of A1C and overall improved glucose control, and you get reductions in cost from emergency department and hospital admissions for diabetic ketoacidosis, severe hypoglycemia. So the benefit is tremendous in terms of improved medical care, but also in terms of cost. So that's why we at DLC and the ADA have broadly sought to have these Medicare and commercial rules lightened up for anybody who has type 2 or type 1 diabetes to have access to these what are important life-saving devices.
And to add, when they did the diabetes test strips and meters, we published the data in Diabetes Care in 2017. What we found with that analysis, which was rigorously reviewed, is that once people got disrupted, so you have to re-go through all your documentation to the new supplier. So Dr. Anderson and his team would have to resend all that documentation, refax all that stuff to a new DME for a Medicare beneficiary who's really not fluent in the healthcare system and process. And what we found is people that cut back on self-monitoring, even with a test strip, higher emergency room visits, higher hospitalization rates, longer length of days stayed, and an increase in mortality. So they've tried this once with the diabetes community. It's a little bit odd that they're going to this degree into April's comments. They're wanting to push all the accountability and responsibility that's held by the CGM and the pump manufacturers that they own through regulatory. So I'm not too sure what their impetus is to try to drive this.
Um, there are also some questions about the logistics of returning a pump. Some people in the chat are asking, how do you rent out a CGM? They're disposable. You change them every 10 days. How does the rental process work for those exactly? April, if you wanted to jump on that one.
Yeah, so basically, I mean, it's great questions because this has never been how payment for CGMs or pumps worked under Medicare before. So it's all very confusing, and we don't know exactly how it would be implemented. But what I'll say is how the payment would work is there would be like a monthly payment rate, and your payment rate as a Medicare beneficiary would be based on that, and that monthly payment rate would include the rental cost for the device itself. So for a CGM, that would be the receiver, and the rental of that, and the insulin pump, and then all the supplies, as it typically does now, would be included in that cost as well.
Okay, thank you. Sorry, I'm like trying to keep, there's so many questions, I'm trying to keep up.
Sorry, I saw another question about how it would work for like Part D, like patch pumps, like Omnipod that go through a pharmacy. So under Medicare, the competitive bidding program would just be for pumps and CGMs, which all CGMs in Medicare are under Part B. So pumps like Omnipod, the patch pumps, would not be included in this proposal. So that can cause other problems as well on people having access to some devices but not others.
Thank you. So my next question, we will try to get to some more in the Q&A as well as we go through this, but my next question is, people with diabetes often need different technology at different points in their journey. How would reducing supplier options impact people with diabetes' ability to find what works best?
Well, in many cases, depending on the payment rate that's established by Medicare, suppliers have perverse economic drivers. Whichever product that they can make the most margin on is the products that they will push. That's what happened with diabetes test strips. The low cost, the low cost products are the ones that they promoted. If you wanted at the time a LifeScan, Bayer, Abbott, or a Roche strip, they would say, well, we're having supply problems, but we got one that's just like it. Why don't you try that and we'll send it to you?
Yeah, just underscoring the need for individual preference. As you highlighted, a lot of my patients, we have the people who are very sophisticated technology-wise, and they can use some of the more complicated algorithms, pumps. We have people who need things simpler. We need patients who, crawl under houses, and they would rather have a patch pump than a tubing. It's just in that's why patients are pretty careful when we start doing insulin pump therapy to select the pump that fits their particular needs. And I think, you're not only shrinking the number of suppliers of these, but you're going to be shrinking options, to Bruce's point, if all of a sudden profitability becomes a driver in which pump you can get.
At the end of the day, the only two people that really count for the decision on technology is between the patient and the physician. Because as the physician knows you as a patient with diabetes, they understand your lifestyle, they understand your issues, your ability to grab hold of all the technology and so forth. And they can pick and choose what's going to work best for you, because everybody's interested with having the best possible outcome. And this sort of removes that trust in the physician-patient relationship.
And on that note, there are a couple questions asking who is benefiting financially from the competitive bidding process.
The ultimate objective is that CMS wants to reduce the cost to the federal government. By reducing the cost for patients that end up paying a copay for their technology, it would be a 20%, the 20% copay would be less. But at the end of the day, if your therapy fails, they save money, but at what cost?
Yeah, and I would just add to that, I think this proposal, all the pieces of this has to work in order for the system and patients to save money. So, that is the goal of competitive bidding, but first of all, we can't lose access to these technologies in the process. And then all of these sort of stars have to align for that to be able to happen. So I think, theoretically, some parts of this proposal sound good, right? If you're renting your device, you might be able to switch devices more often. As John said, a lot of patients don't really need or want to use that option. But a lot of patients also need the comfort and the access to their pump through owning it, right? So they don't have to give it back if something changes and their care is interrupted. So, I think theoretically some of these some of the aims or goals of this might sound good, but in practice, it's not going to work. And then Bruce mentioned earlier, the suppliers aren't prepared to take this on. So at the very least, you can't implement something like this so quickly without a lot of stakeholder engagement and feedback.
And just one other thing, Amanda, a lot of these pumps will go through algorithm updates. There's a thing called automated insulin delivery, AID, where the sensor communicates with the pump, and periodically the manufacturer will issue updates, which the patient can get new software just by logging in and downloading software. Are we now going to have the DME companies be in charge of algorithm updates? How's that going to work for patients? Who's going to own that if they actually own the pumps? There's just a lot, to April's point, there's just a lot that needs to be revisited here before a rushed decision that could have pretty dire consequences for my patients.
Yeah, and I'm seeing the point about the receiver. I think we brushed over that pretty quickly, but correct me, April, at any point if I say something incorrectly, but the part that the DME will own is the receiver. And most people, when we operate our pumps with our separate devices, we use our phone. We don't use the receiver, but you will have to send back the receiver. Like it's a part that no one really uses anymore anyway, and it's obsolete.
Yeah, yeah. I mean, I would say, there are still people who use the receiver, and under Medicare, technically, you're supposed to get a receiver, just because of the way the regulations and the laws work. So, but to your point, I think the reason we focus on insulin pumps when we kind of talk about the interruptions to care here is because a lot of people don't really use that receiver day to day. They're using their phone and their supplies. So this, has the potential to be more of an interruption as far as pumps. But to your point, also, there are people who still use the receiver. And so it would change things for CGMs as well. And just to address one other question that seems to be brought up in the Q&A, there are some questions on whether this would change coverage, so who gets access to these technologies under Medicare. This would not change who is eligible for a CGM or an insulin pump under Medicare, and we've been fighting for years now to get updated coverage for insulin pumps to reduce some of the barriers to accessing an insulin pump under Medicare. And so I think as a patient group, we wish that CMS would focus on some of those efforts and improving access and coverage to align with current guidelines and from societies and associations like ADA, instead of, putting up more barriers to access.
So have we seen similar rental or competitive bidding models anywhere else? And if so, what lessons have we learned from those experiences?
The first lesson was the one where they tried to do diabetes test strips and meters. On one hand, we published a study in 2017 in Diabetes Care that pointed out the challenges and the impact to patients. CMS summarily dismissed it. The article, when Congress looked at it and said, this is not good policy if it's having that amount of detrimental impact, and they stopped the competitive bidding program. But this complete change that they're suggesting now with CGM and insulin pumps, that the suppliers are all of a sudden supposed to have this mass expertise of diabetes equipment. What happens if they have a medical device report? That's statutorily and regulatory, that's what a manufacturer's requirement is. They're not equipped to do that through a DME supplier.
There was another question. Does this only impact people on Medicare and Medicaid?
This program only impacts Medicare beneficiaries. The payment rate within 6 months, if they establish a lower payment rate, will be adopted by commercial plans and be adopted by Medicaid programs. And depending on the delivery methodology, whether it's be through pharmacy, if the rate goes down too low and a community pharmacy can't fulfill it, then you may have greater access problems.
Sorry, April, were you going to jump in?
No, Bruce is right. It's, it's proposed for Medicare, but as we know, policy changes and pricing changes in Medicare have the potential to impact all other kinds of plans in the future.
Well, and also remember, my patients who are on commercial insurance every day are aging into being Medicare beneficiaries, and they own their pumps and they own their technology, and they have a way of dealing with manufacturers with their devices. And all of a sudden, they come to the end of their reasonably useful life of their device, and now they're starting to rent from a DME company they've never had any interaction with before. Again, to Bruce's point, access can be really disrupted with this policy.
Well, and to build on that point that Dr. Anderson just made, the amount of time that he and his staff have to do when you age into Medicare, that first transaction covered under your Medicare Part B benefit, you have to basically prove you still have diabetes. And if you're on an insulin pump or have type 1 diabetes, Dr. Anderson is going to have to order a peptide test and a bunch of documentations and tests that have no bearing whatsoever on your therapy, but it's just adding expense and uncompensated burden and costs on the time that Dr. Anderson and his peers across the country are subjected to.
If you've had type 1 diabetes for 30 years and you age into Medicare beneficiary, I have no idea where your original antibody tests are. I have no idea where your original C-peptide is. And he's right. We're going to have to bring you in, and we're going to repeat meaningless tests simply to jump through a hoop so we can get you what you've had for 30 years.
And I'll just add one other thing that we haven't brought up yet. The great thing about these technologies is they're rapidly evolving and new technologies come on the scene all the time. But as we know as patients, AID systems connect CGMs and insulin pumps so they can work together through an algorithm. And not all devices are going to be interoperable right away. That takes time. And so that also has the potential to be a problem with this proposal, if you can't access the CGMs that are interoperable with your pumps and vice versa.
So if this is from Aaron in the chat, if my DME supplier owns my pump, do they own the data that is in it as well?
That's a good question. That's not addressed in the proposed rule from CMS.
I think one of those additional burdens that suppliers would need to do is if they're taking the pump from one patient that was renting it and giving it to another patient, they would have to wipe that pump of all the data. And that's just another thing, as Bruce and John have pointed out, that suppliers don't currently do that type of service and would have to figure out how to do that.
I mean, you're asking them to suddenly have in their hands an expertise they have never had before, be able to cost it out, put in a competitive bid, knowing they're going to have to hire that extra expertise to service patients. I don't know how you make an accurate competitive bid. And then the other question I have is, if we're taking this down to 2 to 10 DME suppliers across the United States, and a third of them find out financially they can't make this work, what happens to access for our patients?
There are going to be long periods of disruption, because all of a sudden, if you're a losing bidder, there's no, other than a commitment to the patient, there's nothing to say, hey, I need to send it to this winning bidder to facilitate an easy transfer. And those, the winning bidders, they're going to have to go out and do that documentation to make sure that they have it in their format, in their records, and verify that the records are accurate. So you could go through a period of 6 to 8 weeks where you can't acquire pump supplies, CGM sensors, all for waiting for the paperwork to get through.
Yeah, and that just underscores the fact that although it seems to cut costs on the surface, inevitably ER visits, complications will go up and it won't really be a cost saver in the end.
Right. The global
Uh,
cost will far outstrip the unit cost of the devices themselves.
Yep. They want to save money, but at what cost?
Yeah, so we're all asking at this point, what can we do about this? So we've had over 800 of our advocates submit comments to CMS during the comment period last month. A total of 900,000 people nationwide submitted comments, which is amazing. But how can advocates and organizations influence CMS moving forward? And what is the timeline of this?
I think the biggest, go ahead.
I can just start with the timeline that CMS statutorily has to finalize the rule where this was included, which was the home health annual rule, by November 1st. So we're expecting that final rule by October 31st, which is the Friday before November 1st. That being said, CMS doesn't have to finalize this proposal, right? They could say they're delaying implementation of it so they can consider comments. They could address it in future rulemaking. So, our goal is to really get as much pressure on CMS between now and then to say, don't finalize this, don't implement this in 2026, and then have more conversations with CMS and members of Congress so that they can talk to CMS to say why this isn't going to work. And if they want to lower costs, how else they might do that and not hurt patients.
The biggest thing that I think individuals can do is use their voice. Contact your members of Congress. When they're out of session, they're going to be at home meetings in your vicinities. Go to the meeting, express your concern. For those who are attending this discussion, your voice is critical because you're a constituent. And when constituents talk with them, say, hey, I'm concerned. The questions that have been asked, well, what about all my data? Who owns my data? That hasn't been addressed. Who's going to service it? Do they have the ability to do everything that CMS is asking them to do? Ask your congressional delegation, please look into this so I don't get harmed.
So April, for those of us who have submitted comments and did it last month during the comment period, is there any follow-up? What happened with the comments? Did they hear us?
Yeah, absolutely. So CMS has to review those comments. As you noted, there was an extremely high number of comments submitted. Now that rule included other policies, not just this policy on CGM and insulin pumps, but we know that a lot of the comments were about this issue. And so they will review those and they are supposed to respond to those concerns in the final rule that they issue. If they choose to address this policy in the final rule, again, they could also, table it. So I think, first of all, to say the community has been doing a great job of making our voices heard. And, now is the time to continue that work and continue to put pressure on CMS by members of Congress, as Bruce noted, because, members of Congress have influence over CMS as well. And, potentially more so than we do just from submitting a comment letter. So it's really important to contact your member of Congress and ask that they reach out to CMS and explain the problem that this proposal causes for patients.
And can I ask April a quick question? Who is the diabetes expert within CMS?
Yeah, I think it depends on, what kind of policy it is, if it's coverage or coding or payment. But DPAC and DLC and a lot of our other associations and groups we work with and coalitions are working to get to those people at CMS who are really at the center of this proposal. and, talk to those people as well. And it's not just CMS, the Office of Management and Budget, OMB, has a say in this as well. So as John, as you said, it's really important to talk to the right people, and DPAC is going to be sending out some more information on next steps on what our advocates can do to make their voice heard in this process. And we're happy to, include all the contact information you'll need.
Thank you.
Mhm.
So for people who want to reach out individually to their members of Congress, someone's asking, is there a policy number or title of the proposal that they should reference, or any other key questions to ask, essential things to note if they want to do that?
Yeah, so this was included in the home health proposed rule. So you can reference that. And again, like with the resources we'll send out, will help people with that. But I would just, using your voice as a patient is really beneficial, because you can explain how this proposal would impact you and patients like you, if you're not on Medicare, but one day will be. So you can reference that it was included in the proposed home health rule, and explain that it's the competitive bidding proposal for CGMs and insulin pumps. But I think just hitting some of the points that we've talked about today on how this would interrupt patient access, and then specifically asking that member of Congress or office reach out to CMS specifically to ask them not to finalize this part of the rule, is really important to include.
Thank you. And can you tell us a little bit about what we are sending out in the next week or two to our advocates?
Yeah,
Sorry.
we'll be sending out information, so like a draft letter that then you can add your personal experience to, and that will allow you to click and directly send that to your member of Congress. And so we'll be sending out a link for that shortly.
Thank you. Okay, so assuming the rule is implemented, what safeguards could help mitigate the most harmful effects?
I think one of the biggest safeguards is that they must have a monitoring system in real time with an outside independent organization to verify that access is not adversely impacted. Because if you don't track it, how are you going to know?
Yeah, I mean, I think we're in a little bit of uncharted territory if this is implemented. So as DLC and DPAC will be watching and engaging with CMS on this. But I would also say CMS has so they mentioned in the proposed rule that part of the rationale for doing this is that patients wouldn't have to wait that 5 years to get a new device. And I would just say that CMS has the ability to reduce that wait time without going through this whole proposal and changing the category and implementing competitive bidding. So, hopefully maybe they'll take some other steps as an alternative to this, but we will just have to wait and see and engage with them and members of Congress, as we said.
Great. Thank you. And we also have resources on the DPAC website for places to reach out for emergency insulin, emergency supplies. It's called What to Do If You Lose Health Insurance. I will post that following this video conference. And yeah, is there anything else that people absolutely need to know leaving today's webinar?
I would just say thank you for the interest in this, and I think it's been really great to see the diabetes community come together on this issue. And it's a huge change to make all at once, and they haven't really done this before. All of these changes combined at one time in other spaces. So it's really important that we speak out as the diabetes community.
And we've seen what's happened with strips. And I just want to remind everybody what my patient with type 1 diabetes was telling his friend yesterday about all of what he has with his pump. He's sensitive. This is a life support device for me. This isn't something I can live without. This is a life support device. We better be sure we get this right before we disrupt that kind of care.
Yeah, absolutely. I'm sorry that we didn't get to all of the Q&A questions, but if you have questions, feel free to email us at info@diabetespac.org. Or you also know our social media. You have our email. So thank you so much, everyone, for joining us. Thank you, Dr. Anderson. Thank you, April. And thank you, Bruce, who is already gone. Thank you for joining us today and giving us your valuable insights. We're hoping for the best.
Thanks, everybody.
Bye.